Okay, so the first thing to kind of go over is a review from week 1, but in a little bit more detail. So we're going to go over the central venous pressure. So the CVP, this is the pressure returning to the heart from the body. So you can kind of think of it like a right atrial preload. So it's preload is referring to the pressure that's built up somewhere in the heart. So preload in this case on the right atrial is where the blood is going to gather immediately coming from the body. So that is that pressure that is building up there. So the things that I want you guys to be able to answer is what is this value? Because you're going to need to know what the normal value is so that you can interpret questions based on them giving you the value. So who knows the value, normal value for CVP?
Is this like 1 to 6?
Close. I mean, I guess it depends on, yeah, it depends on whatever literature you're looking at, but it's approximately 2 to 8. I have seen different values though. As long as you're in the ballpark, you should be fine. But you do need to know the approximation of this, or you're kind of cooked. But so when you have a CBP value, this is again the amount of pressure that you're getting from your body in terms of blood, and then it's coming back to your heart. So if you have a decreased amount of it, or just on the lower end of this value, is still kind of counts for the same thing. If you have a lower amount, a decreased amount of pressure coming from your body back to your heart, what do you think that tells you in terms of your fluid status?
Hypovolemia?
Yeah, so we call this like dry, and then obviously the opposite would be opposite. So dry, aka it's kind of saying you're hypovolemic, you're lacking fluids, and here you're going to be hypervolemic because you have a lot more to play with essentially. So if you're hypovolemic, and I know we've gone over this, so that's why I'm going through it a little bit quickly. You don't have fluids. What do you give? You give fluids, right? So the intervention for being hypovolemic is giving them a bolus. Sometimes it might be, or in this, at least in this case, because it is essentially the buildup of pressure coming from the body to the heart. It is essentially your how much fluid you have to work with. Um, so sometimes that means it's low fluid, sometimes that can mean it's just that fluid is in the wrong space. So kind of like third spacing. So you have fluid volume that's okay, but at least throughout your whole body, but it's just not in your circulation, meaning that you're not really going to make use of it, but you could be really edematous. So maybe it's fluids, or maybe it's fluids with something that can bring it back into circulation. So maybe like albumin, or anything that could cause fluid to kind of return to your circulation. Um, but if you have too much fluid, in which case the intervention is going to be diuretics, because now, the opposite is true. You have too much, and that can stress out the heart. Because if this is pressure buildup in the heart, if there's too much, then your heart is now having a harder time getting it through. And then that, of course, can lead to um, that struggle that can lead to possible heart failure over long periods of time, or it could be a cause from heart failure to begin with. So these are the kind of things to keep in mind. The next one that is important to know is they call it the pulmonary wedge pressure, also known as your left ventricular and diastolic pressure. I'll write it down. This is a pressure that is measured a specific way. So last time we discussed this, We discussed how this is the one that you need a balloon. You need to inflate a balloon in order to calculate the pressure, which is why it's called a wedge pressure. Sometimes it's also called occlusive pressure because you have to occlude it with a balloon, and that gets you an estimate um, of the pressure returning to the heart from the lungs. So now the CVP again from the body to the heart. The right side of the heart is going to pump the blood to the lungs, and then that once it gets to the lungs, there's exchange of oxygen with the blood, and then it returns back from the lungs to the left side of the heart. That is the pressure that is estimated by this value. So that is, you could also think of it as a left ventricular preload. So the pressure that's now built up in your left ventricle from your after coming back from your lungs. So what is this normal value?
Four to 12.
Yeah, so this is 4 to 12. So kind of like what's written here. If this value is high, that means there's a big pressure buildup in your left ventricle. So why might that be the case? It could be because there's too much fluid going on, so the hypervolemia. So for example, if you have a lot of fluid in your circulation and your body's able to pump it through, you're going to have that high pressure buildup for the same reason you're having that high pressure buildup on the right side of the heart. The same thing is happening on the left. Or it could be due to pressure building up on the left side of the heart because you're unable to pump it appropriately out to the rest of the body, so it starts to build up. So having a high pulmonary wedge pressure could be a sign of left-sided heart failure or hypervolemia. When it's low, it's again kind of coinciding with same thing with the CVP. It's low because maybe you don't have enough fluids going, so there's not enough pressure built up there. Alternatively, another thing that could be the cause, um, it's possible that you might have a lot of pressure buildup in the lungs. You might have heard of pulmonary hypertension. So with pulmonary hypertension, the body on the right side of the heart is now having a hard time fighting the pressure in the lungs and struggling to get as much through due to the high pulmonary um, pulmonary arterial pressures, which you can kind of think of it like an afterload, because the afterload is what your heart has to fight in order to pass through. David mentioned cardiogenic shock having an increased occlusive pressure, which is true for the same reason that if you're having, because cardiogenic shock is pump failure, so if you're not able to pump, pressure again is going to build up on the left side of the heart. I'll include it again. So one of the interesting things about cardiogenic shock, or I guess it's not really interesting, it makes sense once you think about it, is that that one is going to have high amounts of CVP and occlusive pressure as well, that type of shock. Because it's pump failure, you're not able to pump things through, so you're having buildup on both sides of the heart, which is why those pressures would then be increased on your monitor. So this is something that you can get from a Swan Scans monitor, Swan Scans catheter. Okay, so the next one you're gonna need to know is your cardiac output. So what is that number? Hmm?
4 to 8.
4 to 8, yes. Alright. 4 to 8, this is going to be liters per minute. I don't believe we're going to actually have to calculate it, but just for the sake of knowledge, the formula for cardiac output, if you um, have been tested on it before, heart rate times your stroke volume. Stroke volume is calculated in um, mLs, I believe, mLs per minute. So you divide by 1,000 to get it to liters per minute. So that will be your cardiac output. But you want to know that you'll the way I remember questions being like, it's you'll have a patient, you might have some symptomology, so some complaints of this, whatever. But they'll also give you the values, like they'll give you a CVP, a PAWP, might give you the cardiac output, and then the question is asking like, what do you expect the intervention to be, or what is your first intervention, and then whatever nuances come from that. But of course, that does require you to know the values so you can make the interpretation. I included this one just for completion's sake. I don't, uh, they don't test on it. Pulmonary arterial pressure. So this is what I was talking about, the pressure that's built up in the lungs. But it's also because it's an afterload. You can think of it like a right ventricular afterload. So it's the pressure that your right ventricle has to fight against to stuff, get stuff flowing. I do have the value that that it is, but again, you don't have to know that. This one's for future reference if you uh want to know, maybe you want to work in the ICU, etc. This is one that is calculated automatically, like continuously by the Swan scans, so you don't really um have to do anything. It'll just show up on your monitor. But the idea is if you have a high pressure there, that's that pulmonary hypertension, blood pressure built up. Part of the reasons that could be caused could be left-sided heart disease, lung disease, pulmonary embolism. Another thing that could cause it is even like sleep apnea. Sleep apnea could cause a buildup of pressure because you're not breathing throughout the night. You're not breathing throughout the night. That You become a bit ischemic, so compensation wise, your lungs start constricting, or yeah, constricting, so it ends up building a lot of pressure in your lungs. And something to note is that whenever you have chronic pulmonary hypertension, that can then lead to heart enlargement of the right side of the heart, because your right side of the heart is struggling to get blood through, so it hypertrophies in order to compensate. So now you're putting a lot of stress on the right side of the heart. That can lead to right-sided heart failure, which is also called cor pulmonale. So that is something to keep in mind, just kind of like as future reference. Uh, there's that relationship, very strong relationship between the lungs, very strong relationship between the lungs and heart. Um, Something else, again, here listed, but not something that you're going to be tested on, but it's just kind of like a complete thing of everything that's hemodynamic related is systemic vascular resistance. So you can think of it, this is kind of like, as it says, systemic. So this is essentially the pressure, the afterload of the left ventricle, meaning the pressure that your left ventricle has to fight against to be able to circulate blood throughout your body. So this is essentially a measurement of how clamped down your body is. So, how clamped out your body is, kind of like how when you take a regular blood pressure, that diastolic value is essentially your resting pressure. So you can kind of use that to tell how clamped down someone is. Hence why, as review for shock, one of the specific things about signs of shock is that you have a narrow pulse pressure, meaning that your systolic and your diastolic are close, numbers are close to each other because it's showing that the diastolic is showing that you're clamping down, while your systolic is trying to keep up the pressures because it's compensating at that time. So that's an early sign because it shows that your body is being compensated and it's currently clamping down. So at some point, after continuing to try to compensate, that's when you're going to start having your pressures dip because your body's not able to compensate anymore. And so during shock, that's what can be expected. So don't really need to know the values or anything or even the formula. Mm, this formula, there's a formula for this as well, but again, don't have to worry about that. And then stroke volume, that is 60 to 100 mLs per beat. I don't think they ever test you on this one, but the good thing about it is that it is similar to your normal heart rate, 60 to 100. Another value that they are not going to test you on, but is something that you can get used is a venous blood gas. So this is there, shows you how much O2 the body is using. So the idea is that if you have a lower amount that is calculated from getting that blood sample, there is a decrease in cardiac output because it's showing that your body is requiring a higher amount of oxygen than what is expected. An important thing to cut to mnemonic, I guess, is called CRAP. Pretty sure he still uses that one. There are factors that affect the cardiac output. So examples would be contractility, the rate, the afterload, and the preload. We talked a lot about preload already. Again, that is the pressure that is built up on a particular part of the heart. It's also indicative of the stretching of the heart measured by the CVP, at least for the right side. The PAWP would be for the left side. And it follows a principle that we're not really getting it tested on per se, but they call it Starling's law, which is the idea that bigger stretch and bigger stretch of the heart is going to lead to bigger contractions, but this has diminishing returns. So you can kind of think of it like maybe you have a um, maybe you have like a rubber band and you're using it to flick things. The more you stretch it out, the farther you can shoot something with that rubber band. But over time, you're overstretching it. So you're you can kind of think of that overstretching. So over time, it overstretches and becomes weaker, flimsier, more likely to break the rubber band. Uh, it might not fling as fast. It's not going to be as tight if you try to wrap it around things. So you can kind of think of it like that. So over a certain point in time of continuous stretching, it's gonna start being a net negative. Afterload refers to, again, the pressure that you're fighting against to actually make things through. And this is basically your systemic vascular resistance or your pulmonary arterial pressure, the pressure in the lungs. As for the rate and contractility, the rate is pretty self-explanatory, but it's worth noting that once it gets to a certain point, it's now going to it would cause a decrease in the cardiac output. For example, you can be beating faster to compensate for whatever else is going on, right? Your heart rate increasing is a common compensatory factor. But if your heart is pumping too fast, then you're not actually getting a good amount of blood through. So it ends up being counterproductive for the increased beatings. And then the contractility, how hard it's able to pump, will naturally impact how well your heart is doing. So there's going to be medications that we'll talk about that help to increase how strong your heart is able to pump. So now cardiogenic shock, some of the causes are listed here. The manifestations, like we talked before, high occlusive pressure, because there's pump failure, so buildup of pressure. High CVP, pump failure, buildup of pressure. Your body is going to make the effort to compensate. So heart rate increase, respirations will be increased too. High systemic vascular resistance due to clamping down. So this would, I'll even add, and it also come with like an initial increase in diastolic pressure because of the clamping down. But in terms of just hemodynamic, like the pure monitor based thing, it'd be like the systemic vascular resistance. So again, just your measure of clamping down and decreased cardiac output because you're having a hard time getting things through. What are some signs and symptoms that you could expect for cardiogenic shock? In case you guys get a select all that apply when it comes to this, because I know you guys really hate those.
Would it be like signs and symptoms of fluid volume overload?
You would have some of that as well, yeah, for sure. It's kind of think of it like kind of like that alongside some of your signs of shock. So yeah, we mentioned the PVP, rapid breathing. So we'll have shortness of breath. So we said shortness of breath, cold and clammy. So yeah, we'll have decrease in body temperature as everything starts to shunt. So review from shock, everything shunts to the important organs. So your skin is not really an important organ, relatively speaking. So your body will feel a lot colder. So and you'll start to become diaphoretic, pale, cold skin. Say low blood pressure, high heart rate. We're gonna become tachycardic. Yeah, that's gonna be one of the big ones. Gonna be one of the big ones. Okay. Let's see what we get. Low BP. Yes. So we're gonna become hypotensive. What else could be um one of the signs? So we said that. What do you guys think about level of consciousness? What do you guys think about urine output? Altered level of consciousness. If they're awake, they're gonna be anxious, but if it's bad, you're gonna become altered, okay? So low urine output. So remember that when your body is hypotensive, your kidneys are gonna compensate by activating the RAS system, which involves the use of aldosterone in order to cause fluid retention. So your body's gonna hold on to that because it's like, okay, I'd rather keep some of the waste inside in the body as long as I get to keep some of my circulation. Because getting rid of uric acid and all that stuff isn't worth dying. So you make that trade-off. So that's going to be a sign that you might notice is low urine output due to kidney perfusion low. Activation of the RAS. What do you guys think about? So you have fluid buildup in your heart. When there's a lot of fluid buildup and difficulty getting stuff out, what do you think that fluid could end up? What do you think could happen to that fluid? So this is essentially like super severe
Could it
heart
start to like
failure.
back up?
Yeah, so it'll back up. Where do you expect it to back up? Think of it literally like just super severe heart failure.
Like the extremities eventually and muffled heart sound, maybe.
Yeah, so I expect it to possibly build up in the lungs, so crackles in the lungs, or just adventitious lung sounds because of that fluid starts to build up. All that pressure in the heart, eventually the hydrostatic pressure is too much and it starts building up. It can also build up elsewhere. One of the signs of later stage shock in general is edema. It starts spacing throughout your whole body, anasarca. Okay. And then all of this is pressure buildup in the heart, so some chest pain can be expected as well. Okay. Okay, so if we get a select all that apply, that should be you guys should be doing pretty good. So the
Hey
goal of
Diego, is it like is it okay if you like just because we got a select all apply last time, it was like for septic shock and then
Mhm,
hypovolemic shock. Like what will be like a clear indicator of like this is cardiogenic shock versus septic and hypovolemic shock?
mhm. So one of the things that clearly stands out here, let's do cardiogenic versus hypovolemic. So one of the things that clearly stands out here is going to be the crackles in the lungs, right? Because you're not going to get that with a hypovolemic shock because you don't have enough fluid to go by. And one of the things, I guess we can put it here too. It'd be the fluid backup in the lungs. Sorry, fluid backup in the heart. So we're gonna have the hemodynamic changes. So this would be a CBP, the CVP high, the occlusive pressure high, cardiac output low. Those would be the determining factors, and then obviously context clues. So knowing that the patient has a high risk of or has like a heart condition, there's no sign that they are becoming hypovolemic. So like if you know that this person came in with like severe heart failure and they're edematous, and their heart is having a hard time pumping, they have a low ejection fraction. The context is telling you that if they suddenly become hypovolemic, despite being maybe hypertensive, uh, like at the beginning, because they have heart failure, you have that context clue that this could be a cardiogenic related shock as opposed to hypovolemic. So the difference there is, one is low fluid volume overall, while the other one is so much fluid, fluid buildup that the heart can't even get stuff through. So you still have a lot of fluid. It's just that nothing is flowing because it's just backed up. It's not able to um flow things through. Um that and then yeah, I think that should cover it for there. Septic shock, you're gonna have lab values that are different. So septic shock is gonna have you have the whole Sears criteria. So this person could have really high white blood, or could have a high white blood cell count. Um, they could also have one of the things that differentiates septic shock in particular compared to some of the other types of shock is that you will have an initial fever, actually, like a high temperature, as opposed to a immediate low temperature like all of these have, because you're not getting blood flow through. So septic shock will have a higher temperature initially, until it gets to the point where they are so decompensated that then the temperature does go down. So the main differences is cardiogenic shock, you're going to have consequences of that heart failure. So things like crackles in the lungs will be there. Hemodynamics and then context from their history. Hypovolemic shock, they're just not getting fluids. They're bleeding, uh, whatever, something like that would cause them to not have enough volume. Septic shock, they had an infection, right? That would make things a little bit more obvious. They are going to be their skin, instead of being cold, will be warm and diaphoretic, until they fully decompensate. Their white blood cell count will be elevated, or it could be decreased technically. So one of your criterias for SIRS, which is a systemic inflammatory response, is going to be high or low white blood cell count. But this is something a lot of places will kind of just automatically have like a sepsis bundle. So one of your assessments is to be like check these, well, at least at certain hospitals they'll have like a check boxes if it applies. So they'll have you look at the respiration rates, they'll have you look at heart rates, white blood cell count, and if they hit two of those criteria, it moves on to the next thing. It might start a sepsis bundle for them, meaning that they're going to get fluids, um, unless it's already a known infection and it's just being monitored and they don't look like they're decompensated. It'll go to the next thing, which is like, do they have evidence of a severe sepsis? So that would include things such as maybe getting a lactic, like signs of organ uh, compensation of organ impairment. And then in which case that'd be like you're getting lactic acid labs. But in terms of just like the immediate, like you're looking in and you're just looking at the specific symptomology, initially they will be warm. Initially, someone with septic shock could be warm and clammy with a high white blood cell count or a low white blood cell count. Um, but hopefully that helps a little bit there. And then here, of course, you have the hemodynamic measuring and the context. But if someone is struggling, like, if someone is crashing, you're just gonna call a rapid or something, or you're gonna message the doctor, and then the plan of care will kind of go from there. As long as you're able to notice that there's something off, you're already kind of on the right track anyways. Okay. The goal of therapy is increasing that cardiac output, relieving some of that pressure in the chest. And we're going to be doing that by managing that preload, afterload, improving the contractility of the heart. Some diagnostics that will be done, EKG, because you're having chest pain, right? So we're going to EKG to see if there's any long-standing signs of ST elevation, which would be indicative of some heart damage. An echocardiogram is going to be one of your big ones to determine how well the heart is functioning. A chest x-ray, because they'll probably have lung sounds. Abnormal lung sounds, rather. Some blood tests for cardiac enzymes, so they would just check troponin and BNP, all that stuff. Arterial blood gases, just to see what's going on with that. Are they going acidotic? metabolic acidosis from all the lactic acid buildup that happens with shock because you're anaerobic. Okay. And then for management, what do you guys think? What do you guys think should be done? Or what are some of the things that come to mind?
Well, we got to find a way to get the fluid out, right? So, like, depending on the blood pressure, we could give diuretics, vasodilators, or something.
So, so in this case, they are hypotensive though, so you kind of have to be careful with that. I do understand the idea of like if you get rid of some fluid, it might make it a little bit easier for the heart to pump, but they might crash before they get better. So instead of trying to get rid of the fluids right away, they'll try to manage the ability of the heart to actually get things through. So do you guys remember some meds that might help improve the ability of the heart to kind of get stuff through? Your norepi is going to be your first line. Norepinephrine is going to be your first line vasopressor. So we'll write that down for sure. Norepinephrine, also called Levophed. In general, this is your first line vasopressor. There are some medications that you'd want to consider before or alongside in order to specifically improve heart function. So this right here is a vasopressor. So we're just gonna separate it. Dobutamine, yeah. So we're looking for medications that are called inotropic medication. So yes, dobutamine is gonna be one of those. And milrinone is gonna be another one that we're gonna do that. Yes, that's right. So dobutamine, overall, what does this medication do? It's going to help increase contractility, leading to an increase in heart rate and cardiac output. It's going to improve how well the heart's able to pump stuff out. So if you're having pump failure, it helps to get some of that pumping across. Milrinone is going to be another positive iotrope. This one's going to again improve contractility. This one specifically is improve the heart rate, cardiac output. Uh, can cause a decrease in blood pressure. So you gotta be careful with that. I would imagine the butamine is a bit more. The butamine is gonna be a bit more of, I guess you could say, a first line. Then the heart rate is minor, like a minor increase. And I guess a little thing here is you want to use when systolic blood pressure is at least 80, which the reason why is because it can increase the heart rate. So it could cause reflex hypotension due to the increase in heart rate if it's going too much. And if their heart rate's already super high, it might cause that increase, and then your blood pressure compensates for your heart rate. So so you're doing that mix of inotropes and vasopressors, so to try to get things going. So you're gonna keep their blood pressure up by causing them to clamp more, and then the butylamine is gonna help pump more, and then hopefully we can titrate them off. If the vasopressor norepinephrine doesn't work, they could add vasopressin, which is also known as the antidiuretic hormone. So usually if they reach a certain amount of LIBO, so if I recall from what Kaylin has told me, usually it starts at, I believe, 5 mics. I don't remember if that's per hour or per minute, the rate, but it starts at 5 mics and then you increase or decrease by 2. Um, if they hit above 10, then they can add in vasopressin automatically, so antidiuretic hormone as part of your complementary. If that doesn't work, they would add other vasopressors like phenylephrine, maybe epinephrine, and then last case scenario is dopamine, because dopamine is going to be impacting both the blood pressure and the heart rate, and it's a bit more chaotic. So dopamine is not really, it's kind of like a Hail Mary. So remember, this one's going to improve blood pressure, vasopressin, improve BP. Phenylephrine. Also, this one doesn't impact the heart rate as much. These don't impact the heart rate very much. The epinephrine primarily improves heart rate and improve BP. So dopamine is less predictable, so you kind of don't want to mess with it too much. And then I'll include this. So you don't want necessarily don't want fluid. So often they're going to be normal volemic, meaning that they're hypotensive, but they're normal volemic. So they have typically a normal amount of fluid. So they don't need fluids. But fluids don't help improve blood pressure, and it make the heart pump failure worse. Now you're adding more. You're basically increasing the CVP by doing that. Um, so you're not really exactly helping in that case. So it's just there to kind of keep in mind. Uh, any questions so far on anything we discussed? Okay, cool. And then do keep in mind I did not mention diuretics just because they're already hypotensive, so we don't want them to crash before they get better. And in this case, usually, I guess it depends on the person because comorbidities, patients can have multiple things at once. Because this cardiogenic shock can happen due to severe complications of heart failure, which case they're already retaining fluid, but it could also happen due to other reasons such as like a heart attack, an MI. They might not have heart failure, when they get their MI. So they might just have a normal amount of fluid in their body, but then their heart starts pumping well. So they might not even be overloaded per se. So in this scenario, this is like a scenario where you have high CVP and high PAWP, but you're not giving diuretics. So it's kind of like an exception. Okay. The next thing is intra-aortic balloon pump. So this right here is your heart would be like right here. This is the big artery, and it's about to pump everything to the rest of the body. You have this balloon here, and the idea is that this balloon is going to help your body pump in order to improve your cardiac output. So the goal is to improve cardiac output and improve the perfusion to your brain and the perfusion coming out of your heart. So if somebody's having a cardiogenic shock, this can be an indication for needing the balloon pump if they are not responding to the other treatment here or crashing. It could be kind of like an in-between step for them getting a cabbage. So what is the important things you need to know is that it will typically be inserted through their femoral artery, which is on their leg. So the important things that they will ask for this is that they'll probably have like we call it like a stent, not stent, sorry, like their leg might have like something that keep it straight. So they might have a splint to keep not always, but they might have a splint in order to keep the leg straight. Otherwise, you should make sure to remind them if they're conscious, but they're probably not conscious. But at least in that case, that makes your job a little bit easier because you can manually keep it straight. Their head of the bed should be under 30 degrees to not cause any additional pressure on that area. And you're going to want to take care of the skin around it because you have an invasive procedure on a major artery. So you definitely do not want an infection happening there because that's going to go straight into the circulation. You're going to want to maintain a good perfusion baseline. So this is a person with cardiogenic shock. So obviously your priority is going to be related to their perfusion. So you're going to want to do your pedal pulses, especially for this person who has something in their femoral artery. So if something is causing an occlusion, that's the artery that's supplying blood to that lower half of the body. So if they don't have pedal pulses, that's not a good thing, right? Maybe one side of you're gonna make sure that both legs are gonna be the same temperature. They're gonna get equal cap refills. One of them is not bigger than the other. The color, the temperature, as well as the eyes and nose, because this one is important because if you take a look at, well, obviously they're having shock, so naturally they're gonna have a decreased urine output. But with this balloon pump, it should be helping them. But one of the things you might notice here is that the renal arteries are right here, right below the balloon. If the balloon is inserted lower down than it should be, that balloon might actually be completely blocking the renal arteries, which means your kidneys aren't getting perfusion that they need, which might make that urine output even worse. So you want to make sure that they're having enough to be viable, enough urine output to be considered safe. So that would be weight based. So 0.5 to 1 mLs per kilogram per hour. Okay. So some of the complications we'd mentioned, it could be occluding the kidneys. So patient needs to be monitored on their eyes and nose. You can have a Foley in order to get a very accurate, strict eyes and nose, or they should have a Foley. Other complication is the fact that you have this balloon that's inflating, deflating, inflating, deflating. So that can cause damage to the artery. So you could have that balloon weaken the blood vessel, which could cause a dissection, meaning that it tore apart that part of the aorta. So some of the signs of internalized bleeding, just suddenly crashing if they're awake, uh, if they're awake and kind of making that recovery, but suddenly they have flank pain and abdominal pain. They're having signs of um, Turner sign, which is a sign of internal bleeding. So let's take a look at that. So it's that flank, kind of that flank purpling from internalized bleeding. That would mean they need to go to surgery right away because that pumping has caused a tear. And then likewise, that thing pumping in and out can just cause damage, which might cause a buildup of platelets to kind of come in, or even like a rupture of the platelets. So it might cause a decrease in their platelet count, either because it's causing micro damage that causes the platelets to get used up, or just from the force causing some of your blood content in that area to kind of rupture. But the main key things here is you're looking out for signs of aortic dissection and signs of kidney impairment, as well as making sure that the leg is straight. So that's important there for sure. And of course, perfusion guidelines, that makes sense. So I'll highlight all that. So the most important things to keep in mind. Next thing would be valves. So people can have damage to their valves, in which case they will have either a synthetic or a mechanical. The patient will likely be on a blood thinner, an anticoagulant such as Coumadin or warfarin, or Eliquis. Some considerations are listed here. So a lot of that has to do with like post-op. So they're going to be a 1-to-1 in the ICU. They're going to be ventilated. So that kind of goes back to your ventilator bundle. So to kind of review that. Some patient education on Coumadin. Some review of chest tube. And if they're having a valve, you want to make sure they're not having heart failure symptoms. So you're making sure they're not overloaded, or hypovolemic from like internal bleeding, or just, I don't know, some sort of complication there. The next thing here is infective endocarditis. Essentially, infection by bacteria causes vegetation, so kind of like little gunkies in your heart valves in that area. And endocarditis can lead to heart failure, which can lead to cardiogenic shock, an abscess in your heart, and if it's not treated, they will die. Here is a list of risk factors that are good to know. Some of the diagnostics done, so an ultrasound, an echocardiogram, which is going to be like a gold standard. This one's specifically going to be a transesophageal echocardiogram. It's also shortened to TEE. So TEE. This is different from your bedside echocardiogram. It's going to be more accurate, more invasive, more specific, and it's going to be your kind of like your gold standard for detecting the endocarditis. and their blood cultures because it's still an infection. So I'm just going to go quickly through the signs and symptoms. I want to focus mostly on the intervention and management. But it's an infection, so you're going to have some infection, flu-like symptoms listed here. They're having a heart infection, so you might hear some heart murmurs. Heart failure-like symptoms because of the heart infection, making it harder for your heart to function properly. Pain when breathing, and some of these little lesions. As for I believe this is like related to like an inflammatory response by your body. Don't have to really know the specifics on it. Is that just they could have some little lesions on their hands. Splinter hemorrhage is what they call it. Kind of like on their fingernails, these little lines on their fingernails, which is like a late sign. And then from this picture, these lesions are painless. These lesions on their finger is painful. But the important thing here is going to be your management. So they have an infection, so they're going to get antibiotics. They have heart failure-like symptoms, so they're going to be treated for their heart failure-like symptoms. So that would include all your typical management, diuretics, ACE inhibitors, beta blockers, all that stuff, whatever is appropriate. If there is extensive damage to the valve due to the vegetations building up in that area, they can get valve surgery, which will then kind of take you back to the post-op for the valve replacement up there. One of the important things, and I would expect that you are going to get questions on this, is that it is a standard precaution, so they're not infective to other people, because it's all like super internal and localized. Patient education is going to be important, so you want to definitely know this one. It's very likely that you'll get a question related to the need for antibiotics before a dentist. So that dental area, that area where the dentist would be working on is kind of directly leads to your circulation. So if they don't have antibiotics before the dentist and they've already had a history of endocarditis or heart valve dysfunction, it could cause vegetation buildup in the area. So these people need to 100% be aware that they should be getting antibiotics before going to a dentist, or at least for invasive dental procedures. And then some other things would be if they're having really high fever due to the infection, if they're having accompanying chest pain, shortness of breath, flank pains, or severe fluid overload, you'd want to contact the doctor for the acute changes. Okay. The next one, pericarditis. So this is inflammation of the pericardial sac. So that is a membrane that surrounds your heart. It's worth noting that when someone has it, they'll have a high chance of getting it again. Some causes here, but you don't need to memorize any of that stuff. So they're having a buildup of inflammation in their heart. So chest X-ray, because heart, lungs all kind of come together, but also you get a kind of a picture of what's going on with the heart there. So chest X-ray, a CT of the chest, an echocardiogram, EKG. So hopefully, and then some blood labs. So hopefully you're kind of seeing the pattern here for kind of like heart-related things, the kind of diagnostics that kind of go through. Echocardiogram, directly get function of the heart. EKG, see if there's damage to the heart. ST elevation. Chest X-ray, CT of the chest. See if there's hypertrophy. See if there's accompanying buildup of fluid in the lungs, etc. Some of your signs and symptoms here. Chest pain, because essentially you can kind of think of it like inflammation surrounding the heart. So as that heart is pumping, it's going to be making contact with that inflamed part of the heart. So it can cause this chest pain. And one of the key things about this chest pain is that it is relieved with sitting up and leaning forward due to your anatomy. Just that having that positioning will kind of decrease some of the pressure and decrease some of the intrathoracic pressure and make that chest pain less. So that would be something to keep in mind because it could be a question with someone that does have pericarditis about like, hey, they're complaining of chest pain. You already know they have endocarditis, so you could provide. So like maybe you'll have the choice between calling the doctor or seeing if of like your first intervention, seeing if their pain is relieved by sitting up and leaning forward. So just keep that in mind. A friction rub is something you would hear when you listen to their chest. Maybe some muffled or distant heart sounds due to the fact that there's an inflammation of their sac. Shortness of breath and crackles due to pressure on the heart. So pressure on the heart builds up, less pumping, lung stuff. There's kind of all that connection there. So this one you'll definitely need to know. It's called Beck's triad. All right, sorry. So Beck's triad. This is your signs and symptoms that this condition can be progressing into a cardiac tamponade. You will 100% need to know this one. You will have some questions where you're kind of given some symptomology and like the entire point of the question is for you to be able to identify some of these potential signs and symptoms that are kind of showing that the patient is progressing in a very bad way. So 100% you need to know this. So that would be hypotension. So this person has endocarditis. A pericarditis. So they have this heart condition until it progresses to the point of being a cardiac tamponade. Their blood pressure should be relatively stable. If they suddenly become hypotensive, that is a sign that now they're having cardiac tamponade. So cardiac tamponade so now it's not just inflammation. Now it's like a full-on fluid, fluid surrounding the heart. So you have so much pressure in the heart, kind of seeps into that pericardial sac that's already inflamed, and now your whole heart is being squeezed by fluid, because that membrane in your heart that's not supposed to be filled with fluid is now filled with fluid and squeezing the heart. So this essentially causes, similar to that cardiogenic shock, uh, the inability for your heart to properly pump because it's being compressed by fluid. Okay. So having a hard time pumping will lead to low blood pressure, hypotension, alongside weaker pulses because you're having a hard time pumping. Tachycardia because your heart's trying to compensate. It's being squeezed, but it can try to pump faster to try to hopefully make up for it. JVD, so this is where that JVD part of your head to toe assessment actually gets used. JVD, it's a sign of very severe fluid overload. If you guys don't remember, so the JVD would be a very, very, very bloated, or not bloated, but very overloaded vein in your neck. And one of the things you have to do is like if they are lying they're lying flat, you want to sit them up to see if it goes back down. Sometimes they could have that built up there because they are laying down. So set them up, and then if it's still there, then they have JVD. So here's another one where it's less obvious than here, obviously. Here's this one. So if you notice that, set them up, and if it's still there, then they have JVD. If not, then it's benign. That's another one of Beck's triad that you're gonna need to know. And then muffled heart sounds. So this would be, in this case, even like muffled heart sounds. It's already kind of a sign and symptom, but it would be like a change where it's like considerably worse because now it's not just an inflammation of the sac that might be affecting the heart sounds. Now it's that buildup of fluid that's making things even worse. So it's like you're listening to an echo, like a through a tunnel kind of thing. Oh, I guess I already had some. So if they're having a hard time pumping blood, their heart is having a hard time. They're not gonna get oxygen to your body appropriately, so maybe they'll need some O2 supplementation. Same thing with all your shocks, they might need O2. Depends on whatever their vital signs are. Depends on the progress. But it's not like a guaranteed. But if it comes down to it, you'll do it. So here's some general information. I'm not sure why that's. So some consideration of your cardiac tamponade is that your body's going to try to compensate by clamping down. So again, that diastolic is going to be increased. You're going to want to make sure that you're seeing how you're doing your perfusion assessment, right? Maybe this should have been like this. Probably wouldn't. Some medications that you're seeing again, dopamine. So, sorry, this is dopamine. Sorry. Some I guess it is still medication that you're seeing again. Dopamine here. You're seeing dopamine. You're seeing epinephrine. Is this in the right place? Okay. So dopamine and epinephrine, both of those, if you guys kind of recall, impacted the heart rate. So these are medications that could be used for this condition. So dopamine causes a strong heart rate, contractility increase. Don't memorize the doses. Don't memorize the doses. Some considerations to think about is that your dopamine is going to increase your heart rate. So it's going to cause tachycardia, might cause some chest pain because of the increased consumption of oxygen. Your epinephrine. Oh, I see. This should be. I'm not sure what the hell happened here. Let just kind of some of this out. Some of this stuff is in the wrong spot, I think. We'll just go over the diagnostics right now. So some of the stuff you mentioned, it's heart problem, echocardiogram, in order to kind of see what's going on. Chest X-ray can show the fact that the heart is now maybe like a little bit glove shaped, not the right shape because of that fluid buildup. The Swan scans will show these changes in your hemodynamics. So that squeezing of the heart is going to cause increase of CBP and PAWP. So you can see it is very similar to cardiogenic shock in terms of what it how it presents, but of course you get to see through your diagnostics that there is this glove-shaped heart. They it came from, like, a lot of times it comes from endocarditis, or sorry, pericarditis. So again, you're gonna think about your context. Context is important. Again, you're gonna focus on your Beck's triad for the signs and symptoms, and then some generic signs and symptoms. Some of your management is going to be draining the fluid. So they have this little sack full of fluid. You're going to drain the fluid. Well, you're not going to do it, but you get what I mean. They're going to drain the fluid. So that could be directly draining the fluid through a pericardiocentesis, having a pericardial window to relieve the pressure. Treat the shock. So same idea. You're going to be using your vasopressors and your contractility medication. Other considerations include not having any pulses. Pulses distal due to an aneurysm. So if you're having that buildup of pressure, maybe something bursts, something ruptures. So you might have internalized bleeding. And some of this stuff's in the wrong spot. Let me see. Some stuff is in the wrong spot. Give me a second. Okay, I think this is right here. This is actually from an old section I had. So I don't believe they go over AAA in this class. That's a aortic abdominal aneurysm. Does that sound familiar to anyone? I believe that part's not in the curriculum anymore. No? Okay, yeah, so I'll remove it. Yeah, so some stuff got moved around, but okay. Hopefully that wasn't confusing. Any questions on anything so far? Okay, none so far. Okay, good. Okay. Coronary angiogram. The rest of this should be pretty short. Yeah. So coronary angiogram. So an angiogram is going to be A diagnostic used to see how well the blood flow is going, so coronary in your heart, just to see how well it's showing up in your heart. So some of your pre-op is your standard pre-op, so nothing by mouth, no anticoagulants, no metformin for I think it's like 48 hours, because they're getting contrast IV, and the metformin with the contrast IV is not a good idea. It leads to a lactic acidosis, because of the way metformin affects the kidneys, impacts the kidneys in a way that also can make it harder for the contrast IV to clear. Get your baseline vital signs, get your diagnostics done. So pretty typical pre-op stuff. Makes sense. Post-op, monitor vital signs and EKG. So this person will be on a telemonitor. This angiogram will be done either through the radial or femoral artery. So wherever it was done, you want to make sure you're checking it, because if there wasn't enough pressure, or like reopens, you can bleed out pretty quickly from an arterial bleed. So you're going to want to make sure that this person has pulses, the distal pulses from wherever they took it from. Make sure that there's no infection going on, that that site that got the angiogram done isn't cold, different color, different temperature. So all the stuff that makes sense from an invasive intervention through an artery. Check for bleeding, of course, like I mentioned before. If there's bleeding, you're gonna hold pressure really hard, like really, really hard on that area. Call for help. Um, if it's femoral, again, you're gonna have that leg immobilized, because you don't want to move it. That could cause it to reopen and then bleed, big bleed. Head of the bed below 30 again if it's femoral. So again, some of this stuff keeps repeating. So a lot of this stuff ends up being very standardized and very similar. So even this, like you'll see a strict eyes and nose and urine output measurements. So in this case, this is because of the contrast IV. So anytime you're getting contrast IV, you're going to want to rehydrate well to try to flush it out. And then just follow whatever guidelines the patient requires. So if they have a fluid restriction, you just got to be mindful of that. A cabbage is essentially an additional pathway using another vessel, a vessel from a different place to add. Basically, you're adding a new blood vessel for blood to flow through to your heart, in order to kind of make up for parts of the heart that are completely occluded or mostly occluded, in order to improve your cardiac output. So to make an analogy, your cabbage is like you're building an extra lane on a freeway, an extra lane on the streets, so you're allowing for more traffic to go through. So if you have a really congested traffic, you add another lane, and stuff is going to start flowing better. So your peri-op for that, informed consent, it's invasive. Type in cross, because if they bleed out, if they're at risk for bleeding out, you're going to want to make sure you have their stuff is ready, in case they need emergency blood. You're going to want to have them have large bore IVs for blood transfusion, just in case. And keep in mind, someone that is going through the cabbage, going to get a cabbage, they're going to be ending up in the ICU, or they should be ending up in the ICU for follow-up care before getting downgraded. And then some of your post-op is going to be typical post-op splinting, doing their IS, turn cough, deep breathe, moving around. So having them move around, you're holding their telemonitor to see if there's anything crazy that goes on while they're ambulating, see how well they can tolerate cleaning the site, as well as looking at the site where they got harvest site is like the place where they got the vein from. It is very typically on a leg vein. So wherever that harvest site is for their cabbage, just make sure that there's no signs of infection. That area is looking okay. And then here's some things that are expected after the surgery. On the immediate, they'll have a chest tube. So you're walking this person around with a walker, or they have like the cardiac walker specifically at certain places. You can hang your chest tubes on it, have them walk around with their little. You're carrying their heart monitor to see how well they're tolerating. It's worth noting that somebody that's having their heart manipulated has the risk of developing AFib after the surgery. So you're just making sure that there's no complications of AFib. And if that AFib lasts a certain amount of time, you want to let, like, I think if it lasts longer than 2 days without going away, then they're basically gonna be treated as if they just straight up have AFib, like chronic AFib. Someone with AFib within that time frame, um, if they're having like AFib with RVR, so rapid ventricular response, within the first 2 days, they can get synchronized cardioversion because it's fast and symptomatic. But after they've had it for longer than 2 days, the risk of that synchronized cardioversion causing a displacement of possible clots becomes higher and therefore becomes contraindicated. So if somebody's having an RVR episode, that's when they would get cardizem, that's the diltiazem IV, as your first line for management of uncontrolled AFib. Okay, and then over here I have a list of some medications for all your stuff here. So preload enhancers, this is going to be something that's going to improve your volume. So that includes things like fluids and albumin. That's going to help get stuff back in circulation. Preload reducers, things to reduce your pressure that's built up. So that would be like your diuretics. So they're decreasing your CVP. Additionally, making the heart more efficient through inotropes like dobutamine can also help to improve your preload by decreasing your preload. In this case, that inotropic. So think of it in this case like a cardiogenic failure. You have increased CVP. So this one would be too much fluid causing too much pressure. Inefficient heart causing too much pressure to build up. So this is for people that have really high preload, overtly high preload, because having good preload, having a higher preload is not necessarily a bad thing. It's all context related, right? So if you have really low preload, you're going to want to increase the preload. If that pressure is too much, then it ends up like kind of like looping around from being a good thing to becoming a bad thing, because now you're just not, it's showing that there's a pump failure. There's too much in that area and it's going to make it difficult for your heart to get it out, get it all going through. There's a caveat here for so right-sided heart failure. They're going to have a high CVP, but you're not going to decrease their preload because the high CVP is due to pump failure on that side of the heart, but they need to have good preload because otherwise then they're not getting anything out at all. So somebody that is having this issue needs to be maintained through other medications. Or at the very least, not getting diuresed. They should be getting kind of like that cardiogenic failure. They should be getting inotropes, which I know it's ironic because it's here, but they shouldn't be getting so no diuretics. specifically, because they're gonna need they need their preload. The issue is getting it pumped across. So you need more efficient pumping instead. And here's some examples here. Afterload enhancers for basic constriction. I think that's actually where this goes. I was wondering why that was there. I'm not sure how that happened, but it did. So this is going to cause shunting, or not shunting. It's going to cause clamping. So that's what afterload enhancer is. So you can think of it like constriction, clamping. So kind of think about your preload like volume related, and your afterload's kind of like pressure related specifically. Even though preload is also a pressure, it's both your pressure and it's also like how far things are stretching. That one's being measured by kind of like by how much you have to play with, how much fluid, how much volume you have to play with, while afterload is directly exclusively like how much pressure you have to fight against, how much um but it's like both how much your preload has to fight against, but it's also just how much pressure is available to at that area. So for your systemic, that would be your clamping down, your diastolic blood pressure. So that's kind of where that kind of goes in. I'm not sure. I don't have anything there. Whatever. Let me see if there's anything else I can add, and then feel free to type out any questions you guys have. So I can give you guys this, and then I can also give you guys. Where's the medication part of it? I can give you guys this, and then I can also give you guys practice questions, and you guys can do that on your own. Any questions on anything at all? So, anything at all? All right, cool. Let me see. Okay. Okay, so I'll do this because I think this part got messed up a little. There we go. So I added some stuff here. So afterload enhancers, I'm including your norepinephrine, your dopamine, your epinephrine, your phenylephrine, and I don't think they're you'll have to know this, but if you do have levofed, your norepinephrine extravasate, there is they call it quote unquote antidote for it, which the way I think I think it's like you give a lot of it like small little injections in that area, like multiple little small injections in that area that it got extravasated at. But this should give you enough context and enough stuff. Don't have to memorize all the super detailed stuff, but get like a general idea should be good. Let me see what else we got. I'll include this one just in case he started testing it. So afterload, so you have afterload enhancers. You also do have afterload reducers, just so that there's context behind that. So it's be like vasodilation. So that would be like your nitric stuff, nitrous oxide, nitroprusside here. Something to note for this one is that nitroprusside specifically does have cyanide as a byproduct. So there is risk for cyanide poisoning. And this one's like super effective. So it's only used in extreme cases for hypertensive crisis. But I think I might have removed it because I think he didn't test us on it at all. Your classes, I don't even know if they go over it in your class anymore. They went over it in mine. But if they don't, then I really don't think they'll test you on it because they didn't test it on our class. And again, everything that's yellow I think is important for testing, and anything that's cyan, green, blue is kind of nice to know, but not needed to know. Okay. So if you do have a question, feel free to type it out, and then if not, I'll start sending over the files. And then here's questions here, practice questions. Oops, sorry. I guess there's 11 questions total just for practice, and then the answers are always at the bottom with rationales. Okay, if there's no questions, end the recording and then we can be done.